This has been a great session, very translational. We've had everything from cell culture to mice to sheep to guidelines to clinical studies. I'm going to change tack a little bit and talk about something very clinical, and that's the way that we manage patients in shock. I'm going to talk about fluid type, a little bit about fluid amount, and then I'm going to present some new data from our group suggesting that an old hemodynamic friend might be set for a revival. So watch this space for what I'm referring to later on. So I have some disclosures. I am going to talk a little bit about a product that's coming to market that will allow us to measure plasma volume. And so in full disclosure, I do consult for the company that is developing that product. So as I said, we'll talk about crystalloid type. We'll talk about whether colloid is helpful. We're going to see if anything's changed recently in the world of hemodynamic monitoring, and I'm going to show you some new data from our group about pulmonary artery catheters. Those of you that know me well know I use this slide a lot, developed in conjunction with my friend to my left, in which we point out that in every bag of normal saline, which of course is not normal, it's anything but normal, there are 9 grams of salt, which is a lot. And I use this slide to illustrate the fact that every time you hang a bag of normal saline, I want you to think about the amount of salt you are imposing on that patient. And the reason it's important is that the effect on a patient's acid-base and electrolyte balance reflects what we give them. The more salt you give someone, the saltier they become. Eventually, their physiological electrolyte composition will start to resemble the fluid that you're giving them, and they'll start to look like a bag of saline. That does not happen if you give people balanced fluids, and I use the term balance to mean an electrolyte composition that more closely resembles plasma. And the reason this is important is because it determines the effect on the acid-base balance. Balanced fluids don't generate an acidosis to anywhere near the extent that unbalanced fluids like normal saline do. And it turns out you don't actually have to give too much fluid to people to cause a measurable effect. This is Professor Dilip Lobo. He is a surgeon in Nottingham in the UK. And he demonstrated very elegantly 5 years ago now that if you give 2 liters of fluid to healthy volunteers, you can detect measurable changes in both total renal blood flow and cortical renal blood flow almost immediately. And you can see here in these graphs, now how does this work? Yeah. This line here are healthy volunteers given plasma-like 148, which is just a physiologically balanced solution. And this line here are the same volunteers brought back 2 weeks later, but given 0.9% saline. Actually, this was a randomized crossover trial, so every patient was subject was their own control. And you can see that in the balanced group, there is actually a slight increase in renal blood flow. In the unbalanced group, just with 2 liters of normal saline, there's a demonstrable reduction in global renal blood flow and also cortical renal blood flow. So if that happens in healthy volunteers, what happens in unhealthy patients, the sort who we've been talking about this morning? And I would suggest that this is not just a cosmetic effect, this is a real effect with clinical consequences. Now, to get into that problem of whether or not this is real, John and I decided 5 years ago now to do a database study of the premier data set looking at non-cardiac surgical patients. I'm an anesthesiologist, I look after patients having surgery. And we asked the question, is the type of fluid that someone is resuscitated with on the day of surgery important from an outcome perspective? And we showed that it turns out it probably is. There's a statistically significant reduction in a composite of these endpoints here, which include things like gastrointestinal, renal, cardiac, respiratory, bleeding, and infectious complications. There is a reduction in patients who are resuscitated using balanced fluids, and the inset there shows you that there are also more interventions to work up acidosis and more treatments, particularly dialysis, in patients who are resuscitated with normal saline. Now, this is observational data, and I'm usually fairly quick to point out that that does not imply causation. I think that's important. However, at the same time in Canada, Scott Beattie's group, led by Stuart McCluskey, were also investigating the impact of high serum chlorides on outcomes after surgery, and they studied just under 23,000 patients, and propensity matched those who did develop a high serum chloride in the hospital after surgery with those who did not, and demonstrated that, in general, the higher your serum chloride in the hospital, the worse your mortality. And this is a classic epidemiological J-curve, pointing out that in the normal situation here, mortality is lowest. It starts to rise quite significantly once your serum chloride reaches the 120, 125 mark. Again, this isn't proof, but it's circumstantial evidence, and the case starts to build. We had a similar idea around about a couple of years later and said, let's look at administered serum chloride. So this is a different data set. This is 110,000 patients with systemic inflammatory response syndrome in whom we measured the amount of chloride that was given to the patients. We also controlled for comorbid disease load using the Elixhauser algorithm, but this time, because the Cerner data set that we used has physiological data in, we could control for acute severity of illness as well. And we also adjusted the chloride load for the amount of volume of fluid that was administered in order to try and control for the volume effect. In other words, if there is a hazard, is it due to volume or chloride? Well, it turns out there's two hazards, one due to volume and one due to chloride. And you can see here that this is the administered chloride curve, looks exactly the same as the McCluskey curve. Now out here, see how the confidence intervals diverge? That's because mercifully there are very few patients who get 1,500 milliequivalents of chloride in 3 days. That's 10 plus liters of saline. And you can see that by the time you're getting this sort of volume loading, in fact chloride loading, because this is adjusted for volume, your mortality has essentially doubled. So giving chloride to people is a bad idea. Now, we've been around the world for the last few years talking about this, and everywhere I go, people say, yes, but it's just observational data, doesn't mean anything, doesn't mean anything. But this is a particularly prevalent view in New Zealand, by the way. And so we decided to do something about that. These data are from a trial published in the American Journal of Respiratory and Critical Care Medicine earlier on this year from Matt Semler. And remember that name, because Matt's going to be presenting some very provocative data later this year, which I'm going to allude to in a minute. This was a pilot trial in which we asked the question, in our medical ICU at Vanderbilt, where I work, is it possible that we could assign patients to be resuscitated with one fluid type for 1 month, another fluid type for another, and so on and so forth, and cross them over backwards and forwards? So we did that in the spring of last year, and we did actually manage to assign 454 patients to saline and 520 to balanced fluid. So this is an alternating cluster crossover design in order to test feasibility about whether we could actually do that in the confines of a busy intensive care unit. And it turned out we could, and the pilot worked well. And the most intriguing result, I thought, from that trial was the difference in major adverse kidney events at 30 days between the two groups. Now, if you just get a couple of liters of saline, even up to 4 liters of saline, there's no demonstrable difference. And so Split demonstrated that, and many other people would agree that if you just give a little bit of fluid, it probably doesn't matter. But look out here, if you get more than about 8 or 9 liters, there's a big difference. Now, whether this pans out remains to be seen, but we thought this was pretty tantalizing. This is statistically significant. However, it's a secondary endpoint, and therefore we didn't claim a big win for this particular trial. The real reason for doing SALT was to set these two trials up, one called SMART at the top and another called SALT-ED. These are cluster crossover design trials, which are now finished. They were set up in our intensive care units and our emergency room, and together they've enrolled almost 40,000 patients over the last 18 months, depending on whether you were admitted to the ICU or the emergency room. The ICU study design is here. These are our 5 adult ICUs at Vanderbilt, and you can see how you're all allocated either to saline or balanced, depending on when you're admitted to that unit. The outcome in SMART is major adverse kidney events at 30 days. The emergency room outcome is hospital-free mortality in the first 30 days, which is essentially a composite of length of stay and mortality, which we're particularly fond of at Vanderbilt. The thing I'm the most proud about these two manuscripts is that we actually published the R code that will be used to analyze the results from these two studies. And this was code developed at Vanderbilt and has been used in a historical data set extracted from the same EMR. So watch this space within the next 3 to 4 months. These data are being analyzed as we speak, in fact. So that's a little bit about crystalloid. Let's talk about colloid now. There's been a lot of fuss and bother about colloid in the last 3 or 4 years. Synthetic colloids have largely fallen out of favor in most parts of the world, although not everywhere, which leaves us largely with albumin. I'm a cardiac guy, and I study cardiac surgical patients. This was an interesting study I wrote an editorial about, published in the anesthesia literature last year. This was a single-center but double-blind randomized controlled trial in adult patients undergoing off-pump coronary artery surgery, and that piqued my interest because at Vanderbilt we do a lot of off-pump surgery. Not a lot of other places do. And this study used albumin as a drug, and they said if we replace albumin to a concentration of 4 grams per deciliter, is there a benefit or a harm from the kidney perspective? And they demonstrated that whether you used the Akin criteria or the Cadigo criterion, shouldn't be too much of a shock to this crowd to realize that the results were fairly similar either way, then there was a reduction in patients experiencing new onset acute kidney injury in patients given albumin, conceptualized as a drug rather than a fluid. So that set us thinking again. This is Adam Kingerter, who at this time last year was a fellow of mine, who's now a fellow colleague at Vanderbilt. And we asked the question, using that same Cerner data set, can we identify a signal when albumin is used more as a fluid, in other words, in the 5% concentration? So this is adult on-pump cardiac surgery patients, either given albumin or not. A little under, or a little over actually, 1,500 patients, 763 in each group. Again, propensity matched with the primary outcome of in-hospital mortality. And there was a win for both the index mortality and 30, 60, and 90 days, as well as readmission. So that captured our attention. Mortality and readmission, both very important endpoints in the elective surgical community. Again, this isn't proof of causation, but it supports the idea that there may be benefit in heart surgery patients for giving them some albumin. These data are in press in the anesthesia literature. So let's talk a little bit about hemodynamic monitoring and shock management from a very clinical perspective now. The reason we use hemodynamic monitoring is to identify when the physiological situation has changed and become abnormal, and ideally to intervene before complications occur. So things like central lines, pulmonary artery catheters, arterial waveforms have gradually given way to less and less invasive type technology using ultrasonography or impedance and bioimpedance. And my problem with that is that they are purporting to measure something which we don't change, right? They measure volume responsiveness, and volume responsiveness is not volume deficiency. Nobody in this room, I hope, is volume deficient, but almost everybody here is volume responsive. And the reason we measure volume responsiveness is because we can't measure volume deficiency. We have been told by the industry that that's not something that's possible, so put that aside. Well, it turns out it is possible using our old friend indicator dilution. And this is a very simple concept that if you inject a known volume of a known indicator, then you can calculate a new volume by measuring the concentration in that new volume. And so all you do is inject an indicator into the circulation in a known volume. You draw a blood sample later on, measure the concentration of that indicator, and voila, there is the plasma volume. And of course, by including the hematocrit measurement, you can extrapolate up to blood volume, which would allow us, if there was a bedside technology available to do that, to know what the circulating volume is, which would mean we could measure the effect of volume administration, but also removal in real time. And that would be pretty cool. So this is the company I was talking about. They are developing a technology using optical indicators to be able to measure real-time circulating volume, but also GFR is an interesting spin-off. So this crowd should be excited about the idea that soon there will be bedside technology available to measure both plasma volume and GFR. There is also a radioactive technology available in the United States, although I'm not sure about Europe. This is a sample readout from a patient in whom this new technology was used, and you can see these are the sorts of things. It gives you a measured plasma volume, a measured blood volume in the sort of range that you would expect. Here is a dog that was given a bolus of saline. As you can see, there's an initial peak in the circulating volume, and then it settles out as that fluid equilibrates through the circulation and the rest of the ECF. Now, let me talk to you a little bit about pulmonary artery catheters. Let me see if you're awake still. How many people use pulmonary artery catheters on a weekly basis? Is there anybody? Yes, you see the Illuminati here. I'm going to try and show you why I think he and I are on the right end of that distribution. And I'm pleased that none of you do use these things because I like to, those of you who know me know I like to stir the pot a little bit. It is true that we've been told for 20 years or so that pulmonary artery catheters are the devil's work, are dangerous, are harmful, and certainly not beneficial. However, if you ask the companies who make them, sales have never been better. And so there's a disconnect between what we're being told by the literature and by what we're doing as consumers. Now, there's a business adage that the market never lies. So someone is seeing some value in the pulmonary artery catheter. So that was a little bit of a paradox that I thought would be interesting to explore. So I said to one of the manufacturers, why don't we go back to that data set we have access to and ask the question, in patients who are managed with a pulmonary artery catheter, propensity matched with patients who are not, is there a signal? And let's do this completely agnostically. Let's come at this before, let's write what we're going to do down. Let's define our analysis plan. Let's define our way of controlling for confounding before we go to the data set. And it took me a long time to persuade the sponsoring company to do that. But I pointed out that if we were to do that, then the back-end results would be a lot more valid. And we chose heart surgery because a lot of heart surgery patients do receive pulmonary artery catheters. But there's this same disconnect in that community between those who do and those who don't. So these are data which have not been presented. They are about to be submitted for publication. This is adult valve and CABG patients. There are a few transplants in here too, but not many, in whom we matched management strategy with a pulmonary artery catheter versus management strategy without a pulmonary artery catheter. There are a little under 7,000 patients here, 3,500 in each arm. Again, controlling for existing comorbidity using the Elixhauser algorithm and the acute physiology score to control for admission to the ICU severity of illness. And I'm going to jump to the business slide, if you will. No mortality signal, which is good, right? So this idea that there's a harm and a hazard, not true, apparently. There's a reduction in new onset cardiopulmonary morbidity, defined as new onset heart failure or respiratory failure. But there's an increase in infectious morbidity, defined as bacteremia and UTI. So why would that be? Well, it might be fairly intuitive to say, well, there's more bacteremias because there's an intravenous catheter present, but there was no difference in central line-associated bloodstream infections. So we believe that bacteremia is driven by an increased dwell time of a Foley catheter because it's very unusual to take a Foley catheter out of someone who still has a pulmonary artery catheter in. The thing that captured my hospital CEO, who's a good friend of mine's, interest was this reduction in length of stay in patients managed with a pulmonary artery catheter. If that's real, that's very important. Here are the actual incidences, as you can see, reduction in heart failure. The surgeons were interested in a reduction in hemorrhage and hemoglobin drops, perhaps at the price of an increase in bacteremia and UTI. So I hope this is going to stir controversy in the field. Just to summarize that data, no effect on mortality or length of stay or unplanned readmissions. So no win, but certainly no loss either. So if the last 20 years of dogma are true, then we should have found a hazard signal. And remember, this type of study is more robust to confounding when you're looking for a hazard than when you're looking for a benefit. So watch this space for more discussion about that. So in summary, this is my last slide. I believe the circumstantial evidence that high chloride-containing solutions are harmful continues to mount. We will have data from prospective interventional trials, albeit at a single center soon. The Australians and New Zealanders are also running a large trial, and there's also a large Latin American trial. So one way or the other, we will get to the bottom of this controversy. Although if history is any predictor, it's unlikely that all of those trials will present results that go in the same direction. It would be nice if they do, but that certainly isn't the historical precedent. I believe albumin may be helpful in heart surgery. Others believe it's harmful. I do think we're going to get newer tools which will allow us to measure the things that we change on a day-to-day basis, and I'm referring to plasma volume there. And I do believe that pulmonary artery catheters are helpful, at least in cardiac surgical patients. Whether that is true in the generally sick patient is unclear. There's an important difference between 10 to 15 years ago and now, and that is that now we use ultrasound to place central lines, and before we didn't. And there's a distinct possibility that some of the morbidity, I think, was related to that. With that, I'll thank you for your attention, and we're going to have a panel discussion.